All right, welcome. Today, we are diving deep into a topic that is absolutely critical, not just for your MRCS, but for real life on the wards: potassium. This is the stuff that can turn a stable patient into a full-blown cardiac emergency in minutes. So let's get right into it. Everything we're going to talk about is high yield, pulled from the top resources to get you exam ready. But more than that, our goal is to make you feel confident when you're faced with a potassium imbalance. So let's kick things off with a scenario. Okay, picture this. It's the middle of the night, you're on call, and all of a sudden, a cardiac monitor just starts screaming. You run to the bedside, and what you see on the screen is chaotic. It's a dangerous, erratic rhythm, and you know every single second counts. Your brain immediately goes to electrolytes. And just then, the lab calls with a critical value. It's potassium. Suddenly, it's all on you. That patient's life is in your hands. So, what's your next move? Okay, let's open up our first case file. We're going to investigate the silent but really serious threat of hypokalemia. That's low potassium. We're calling this one the U-wave case. You know, the tricky thing about low potassium is just how many different things can cause it. You've got your obvious GI losses, sure, but you also have to be on the lookout for hormonal stuff like Cushing's or Conn's, and this is a big one. Don't forget the things we cause with the lupin thiazide diuretics we prescribe all the time. So what are the clues you're looking for? Well, your patient might complain about feeling incredibly weak, but the real drama is happening inside. Low potassium can actually paralyze the gut, leading to something called a paralytic ileus. And of course, the big one, it messes with the heart, causing those dangerous arrhythmias. And you can literally see the cardiac risk on an ECG. You'll see things like a prolonged PR interval and flattened T waves. But the absolute classic sign, the one examiners love to ask about, is the appearance of a U wave. All right, here's the number that should set off alarm bells in your head: 2.5. Once that potassium level dips below 2.5 millimoles per liter, it's officially severe. We're past the point of just giving some oral supplements. This patient needs intravenous potassium, and it has to be given through a central line because it's just too harsh on smaller peripheral veins. So let's flip the script. We've covered what happens when there's too little potassium. Now let's tackle the opposite problem: hyperkalemia, when the level gets dangerously high. We'll call this one the peaked T case. To get a handle on all the causes of high potassium, this mnemonic is your best friend: AHB cram Dan. It covers a ton, from medications to big systemic problems. I want to highlight acidosis for a second. Think of it like this: the body wants to fix the acid in the blood by shoving hydrogen ions into cells. But it's a trade. To push hydrogen in, it has to push potassium out. And that's what spikes your serum potassium. This also explains why you see it in things like DKA or a bad crush injury. Massive cell breakdown literally spills all that intracellular potassium right into the bloodstream. Back to the ECG. The earliest, most classic sign of hyperkalemia is a tall, pointy, peaked T wave. It looks like a little tent. But as things get more serious, the P wave starts to disappear, and the QRS complex begins to stretch out and get wider. Let me tell you, a wide QRS in this situation is a truly ominous sign. It means you are heading towards cardiac arrest. Okay, let's put them head to head because seeing them side by side makes it crystal clear. For low potassium, I want you to think flat T waves and U waves. For high potassium, think peaked T waves and a wide QRS. This exact comparison is a classic exam question, so you have got to know these patterns cold. So you see those peaked T waves on the monitor. Your stomach drops. This is an emergency. What is your action plan right now? You need a 3-step protocol that you can execute without even thinking. This 3-step protocol is your lifeline. First, and this is the most important part, you stabilize the heart with IV calcium gluconate. This buys you precious time. Second, you shift the potassium back into the cells using an insulin glucose drip. And third, you get the potassium out of the body completely using diuretics or even dialysis. So remember the mantra: stabilize, shift, remove. And what's that magic number that should make you think about getting the dialysis team involved? It's 6.5. A potassium level over 6.5, especially if you're seeing ECG changes, is a huge red flag that you might need urgent dialysis. It's the ultimate safety net. Now, really quickly, let's go over a few high-stakes situations where potassium plays a starring and often deadly role. These are classic exam traps, so you definitely want to be aware of them. Think about this for a second. In refeeding syndrome, when you feed a starved patient, a sudden insulin surge drives potassium into the cells, causing a dangerous drop in the blood. But then you have the complete opposite in tumor lysis syndrome or rhabdomyolysis, where massive cell death floods the blood with potassium, leading to life-threatening hyperkalemia. Two totally different situations with the same deadly electrolyte at the center of it all. Whew, okay, we've covered a ton of crucial information. So let's lock in the most important points with a final, rapid-fire review to make sure you're ready for anything. For low potassium, I want you to burn this into your brain. U for the U wave and flat for the T wave. U and flat. Simple as that. And for high potassium, the key words are peaked for that tall T wave and wide for the QRS complex. Peaked and wide. Got it? And look, if you only remember one single thing about management, please let it be this. In a hyperkalemic emergency with ECG changes, your first, most critical, life-saving action is to stabilize the cardiac membrane with IV calcium gluconate. Protect the heart first. So there you have it, the highs and the lows of potassium. Remember, knowing this stuff isn't just about passing an exam. It's about having the confidence to act decisively when it really matters. So when you see those ECG changes in a real code red situation, the question is, can you apply this in seconds?